What's going on, podcasting world? Welcome back to yet another episode of the Core Consult RX podcast. My name's mcorvino. Cole Swanson is with me as always.
Except for last time.
It's a good point, Cole. Thank you for bringing that up.
I'm not going to let you forget.
Still hasn't quite gotten over that one.
I think you called out my commitment on that podcast.
I did.
Yeah.
It's not going to lie. I think that was 2 episodes ago, actually.
Oh, it wasn't?
So, yeah.
Okay.
So I think you need to Yeah, the double episode record.
Yeah, we flip-flopped them a little bit.
You guys never saw it coming.
Yeah.
Hi to a person on Instagram. It just said hi.
Oh, good.
Hey, how's it going?
We'll wave.
So today, Cole, what are we doing?
Well, I'm going to give a shout out to Tara, who gave us this idea for a topic that I was very surprised we hadn't done yet.
Tara.
Call. PharmD. Osteoporosis. Talking about bones. Very, very common disease state, and I'm really surprised that it hasn't come up in the first 75 episodes.
Yeah, and you checked, right?
I did, yes.
Okay, good.
The only osteo we've done was an overview of osteoarthritis.
So today, one of my students asked me if we have done osteoarthritis, and I said, yeah, it was episode 27. She's like, oh, wow, that's crazy. You have them all memorized. I was like, no. Don't get it twisted. I said,
you texted Cole.
I said, Cole went ahead and sent me a text and told me we've already said it, because I asked him if we've even talked about that before. And so, yeah, she thought that was funny. But, and then one of the other guys from my class was like, yeah, he seems like he's a lot more organized between the two. I was like, yeah, that's a good way of putting it.
We just have a list, that's all.
Yeah.
A searchable list.
Yep. Thank God.
You can thank our host, our online host for that. I don't even know what it's called because you do all that.
See? That's right. We're a great team.
Yeah,
Neither one of us have the clue what the other one does.
I can search topics and he handles the recording stuff.
Yeah, I just push the post button.
Yeah.
And it goes online.
There you go.
I'm basically a programmer. All right, so osteoporosis. So with this one, we're going to kind of do like a brief overview because you can break this down, and obviously based on like postmenopausal women, you can break it down into men. You can break it down into like secondary issues going on, and like medication-induced osteoporosis. There's a whole bunch of things that a whole bunch of different ways to differentiate osteoporosis. So we're going to mostly just kind of go over the drugs that are used, and we'll talk about the indication stuff, but we're not going to go super in depth into any one type, if you will.
Yeah, we could do multiple side podcasts on the different indications and things like that. But I think we'll get a good overview of the most common things you're going to see and what you're probably going to have to deal with in the primary care setting for the most part. And when to screen people and that kind of thing.
Right. So bone mineral density, we'll start there.
Sure, go for it.
So basically, bone mineral density is something that is kind of constantly remodeling and regenerating. And so we have osteoblasts, which are going to be the cells that are going to build bone or cause bone formation. And we have osteoclasts, which cause the bone breakdown or resorption. This breakdown, as people get older or other things can have, going on, whether it's different medications or whatnot, can kind of disrupt the balance, and you get more breakdown than you do build up. And so we need to suppress the osteoclasts and figure out what's going on, and hopefully restore some of that bone mineral density back to its original strength. Yes. Or at least similar strength.
And that's the primary goal of most of the first-line medications. There's other medications, monoclonal antibodies, other estrogen receptor modulators that you can use that are going to target other things. Rank L. We'll talk about one of the drugs that targets that, which is kind of at the end of that process of bone remodeling that you can target. Mike talked about some of the things that can cause it, other things, estrogen deficiency. That's why premenopausal, postmenopausal is very important. Calcium deficiency. We'll talk a little bit about the role of calcium and vitamin D and how that's controversial. And vitamin D deficiency. Yeah, they help maintain the bone homeostasis along with the parathyroid hormone. But osteoporosis is the most common metabolic bone disease. It's very similar to hypertension in that it's very clinically silent until it manifests as a fracture. Hypertension, clinically silent until it manifests as some type of heart event, right? Mm-hmm. There's multiple fractures that can occur. Some are more severe than others. We're all familiar with hip fractures, vertebral fractures, but there's many others. 2/3 of vertebral fractures are actually painless, and they find them later or because someone is having some type of acute pain that may follow a fall or minor trauma. The pain might be localized to a specific identifiable vertebral level, and that's how they find it, and it usually resolves after a few weeks, so they have to do testing to see how severe it actually is.
So some of the medical conditions or comorbid conditions that patients may have where you are more susceptible to developing osteoporosis would be things like a patient that has certain eating disorders like anorexia, patients that have diabetes, certain gastrointestinal diseases like inflammatory bowel disease rather, celiac disease, things like that. Also, hyperthyroidism can play a role. And then menopause is also a big reason. We see it in older women. In general, females do seem to be more likely to get it than males. And then as far as ethnicity goes, usually Caucasians and Asian American women are increased risk. And then patients that are older are typically the ones that we see this kind of developing, as well as patients that have an overall low body weight.
Right. Like I said, it's very common, like he said, mainly women. In 2010, there were more than 10 million adults over 50 years old that had osteoporosis, with 43 million having a low bone mineral density. So we'll talk about how to classify those and how to test for that. Mike talked about that a little bit. In 2015, as many as 2 million Medicare beneficiaries had 2.3 million osteoporotic fractures. So this is why that's important. Fracture might not seem like that huge of a deal. When you're young, you have a cast for a few weeks and you're good to go. But in elderly patients, it's associated with increased risk for subsequent fractures following it, and increased risk for mortality. So mortality was highest in this study from 2015 in those with hip fractures, with 30%. Almost a third of patients dying within 12 months of their hip fractures, which are usually preceded by a fall, which is why, and that goes into a whole other conversation about the Beers criteria, medication safety in the elderly, and the fact that pretty much everything is on the Beers criteria. There's a reason for that. Usually, frequently, if it's a CNS depressant, it's going to increase risk for falls, and if we have a hip fracture, significantly increases risk for mortality.
You want to go through some medications that can potentially cause it?
Let's do it.
So some of our anticonvulsants, specifically like phenytoin, phenobarbital, carbamazepine, can potentially induce an osteoporosis. Lithium can also be one of the culprits. PPIs, which we know that can, because you're increasing the gastric pH, you are going to decrease the calcium absorption, so that can lead to problems. Steroids taken daily, so like more than 5 milligrams or more of prednisone or an equivalent dose of that, taken for greater 3 months or more would be something that we would consider putting a patient at risk for osteoporosis. There's also things like loop diuretics where you're going to get a decrease in calcium. SSRIs have even been known to cause it. So TZDs. So there's several things that can decrease bone mineral density.
That's drug-wise. There are other risk factors. We talked about female sex and Caucasian descent, but history of an adult fracture also puts you at increased risk. Dementia, poor health, those are non-modifiable risk factors. There are some modifiable risk factors that you can talk to your patients about. Cigarette smoking, of course, because it causes everything. Mike mentioned low body weight. We already mentioned estrogen deficiency, alcoholism, recurrent falls. If a patient is physically immobile or just does not exercise very often, that also puts you at increased risk. And someone with impaired eyesight, even if they have corrective lenses, puts them at an increased risk for stumbling or falling.
Get some glasses, people.
Yes. Or contacts.
Yeah, that's true.
Be like Mike and just never take them out.
Listen, why do you got to tell my secrets on the podcast?
We already talked about that on the
Did
podcast.
we?
Oh, yeah.
Oh, boy.
How do you think I knew that?
I don't know. I tell all my secrets on the podcast, and then I forget I say them.
Mm-hmm.
All right. So looking at a DEXA scan, because we have to find out kind of how bad the person's bone mineral density loss potentially is. And so we have this thing called a DEXA scan, which basically gives us this measurement of bone mineral density, usually looking at the spine and hip. And it calculates either a T-score or a Z, like zebra score, is how it's actually kind of interpreted. We base that on, for instance, T-scores. A normal would be -1 or more. Osteopenia, which is considered low bone mass, so not quite osteoporosis, would be -1 to -2.4, and anything less than or equal to 2.5 or less, -2.5 or less is going to be considered osteoporosis.
Yes. And so, unlike golf, a lower score is bad, and the reason for that is this is generally a World Health Organization criteria that define these, and the way they look at T-scores and Z-scores. So, a T-score is a value within one standard deviation of the mean bone mineral density value in a healthy young adult. So, what they consider normal, healthy bone mineral density. If you are at least 1 to 2.5 standard deviations away from that, osteopenia, 2.5 or more standard deviations, like Mike said, osteoporosis, less than 2.5, and then less than 2.5, and then less than 2.5 plus fragility fractures indicates severe osteoporosis. So that's why those values are what they are.
So we're genuinely thinking we're running one of these on a patient, female patient who is 65 years or older, and then for men 70 years or older, should have their bone mineral density checked, and then depending on issues, it could happen earlier than that. So if they've had a fall from standing height or lower that resulted in a fracture, we may even want to check it as early as 50 or maybe a little bit more, but just to check and see what's going on, or if they have a long history of smoking, alcoholism, or if they have a genetic or a family history rather, which would of some sort of a fall at an early age. So we would want to check it at that point. But yeah, typically are only done in our elderly patients.
Yeah, I did want to say that DEXA scan stood for dual energy X-ray absorptimetry. I don't know if I pronounced the last word right, but I thought that was interesting. So Mike was listing some guidelines. There are multiple guidelines. They are all generally similar, so you can probably come up with a rule of thumb for your patients. But yeah, 65 or older for women, 7 or older for men, regardless of any risk factors. And then where it gets more complicated is risk factors and age and menopausal status. If they have had prior fragility fractures, or anyone being considered for pharmacologic therapy, you might want to follow up with that regardless of age, those sorts of things. So U.S. Preventative Services Task Force has some recommendations too. So you can kind of look at those and determine what you think. The best one is National Osteoporosis Foundation, and but they're all pretty consistent for the most part.
Yeah, and then we also have the FRAX tool, the Fracture Risk Assessment Tool, which is a computer-based algorithm. I believe it's got an app as well that you can download, but it's from the World Health Organization, and it basically estimates the risk of having a fracture due to osteoporosis within the next 10 years. And so if a patient, you can also go to the website www.nof.org and look at it on there. And I believe you can download the app as well now. It's 2019 after all.
Yeah, and that's another thing you can use to diagnose. So if you're looking at the National Osteoporosis Foundation guidelines for diagnosis, a FRAX score with 10-year risk for hip fracture greater than 3% or for major osteoporotic fracture greater than 20% in a patient who is osteopenic based on their T-score can be a diagnosis for osteoporosis. And then we also talked about a T-score of less than 2.5 at the spine or hip as determined by a DEXA scan, or if you just have a hip fracture. So if you have a hip fracture, regardless of bone mineral density testing, boom, you have osteoporosis.
Boom.
So,
That's safe to tell patients they have it too. Boom.
Yeah.
You have it. Congrats. Cole told me to say that.
That's Mike's bedside manner.
Yep. People love me for my honesty.
One last, vertebral, proximal humerus, pelvis, or in some cases distal forearm fractures in the setting of low bone mass, so osteopenia, can also diagnose you with osteoporosis.
So, once they have osteoporosis, what are we going to do?
Well, we got to treat them, right?
Well, maybe.
We starting drugs or are we doing other stuff?
So we won't go too much into lifestyle measures, but they do encourage patients to do some sort of lifestyle measurement, whether that's weight training or some sort of like a strengthening exercise. So it can be like a very low impact, like walking or Tai Chi. But you can also do like weight training, yoga, things like that. Should be encouraged, as well as, things like stopping the cigarette smoking and stuff like that, if that's an issue.
Tai Chi's come up in a few guidelines.
Yeah, the osteoarthritis guidelines also talk about it.
Yeah.
Tai Chi's where it's at now.
Yeah, what's
Who
going
knew?
on with that?
It's that whole grab the ball and push the ball away in slow motion.
So,
Highly ineffective for a street fight, I would imagine.
wait, that's what Tai Chi is?
Yeah.
That's like this?
Yeah, right.
The Dragon Ball Z situation?
Well, like much slower though. It's like grandfather's Dragon Ball Z.
Oh, is that what it is?
Very cool. And you have to wear the cool outfit while you do it. Even if you're a Caucasian guy, you look ridiculous. Still wearing it.
So what we need to do is franchise
Ooh.
a Tai Chi box.
I'm listening. A box?
Kind of like CrossFit.
Oh, like
They have their boxes.
Oh, you mean where they have a gym and they just call it a box because they want to?
Because it's square.
Oh, geez. Don't even get me started on that. If you do CrossFit, I'm sorry, but that's the stupidest thing I've ever heard in my life. I refuse to call it that.
We love all our CrossFit listeners.
I used to do CrossFit myself, and I still wouldn't call it a box. I'm like, this is a gym. I don't want to hear it. You're making up terms. Oh, geez. Okay, sorry. This is what happens. Cole gets me on.
This is when we start to lose listeners, right?
Yep, this is when we start losing listeners
keep going with
every week. Okay, so let's start off with calcium, vitamin D supplements, since those are obviously the most readily accessible, and then Cole will talk to us about why we may or may not even like those.
I actually don't have a whole lot on it, to be honest.
Great.
But I
set you up there and you just
I know. I was like, maybe I can pull some of those studies, or maybe I can just talk about how it's controversial.
Love it. Yeah. That's how you improv right there. You know what? I'm going to go ahead and just say it's controversial.
I just wanted to nip it in the bud before you threw it my way.
No, so. I like it. Respect.
Yeah.
So, calcium. The recommended daily intake for most adults would be 1,000 to 1,200 milligrams. The thing about that is you want to make sure that you're separating the doses out, because you really can only absorb about 500 to 600 milligrams of elemental calcium per dose. So if you are taking, let's say, calcium carbonate in the form of, Tums or, Oscal or one of those other, brands that they have, Oyster calcium, whatever the thing's called.
That's exactly what I say in my head, oyster calcium, when I see that.
When you see oyster calcium on a test, it's calcium carbonate. Don't let them fool you. But anyway, so that's about 40% elemental calcium. So if you're taking, 10,000 milligrams, you're not all of a sudden absorbing all this calcium. You're not even gonna absorb most of it. You're gonna just pass it right on through. Calcium carbonate is also dependent on an acidic environment. So if you have a patient that is on a PPI or even like an H2 blocker, but especially a PPI, and you're giving them calcium carbonate to replenish calcium levels, please stop doing that, because that is dumb. Give them calcium citrate. The citrate makes it to where you don't need an acidic environment. They're not acidic dependent, and you will still get it absorbed. You'll still absorb some of the calcium. So it's not quite as much, about 21% of elemental calcium, but you can take it with or without food, and you don't have to worry about what else you're taking it with.
Mike loves calling people dumb on the podcast.
That's fine. They know I'm just kidding. It's all love.
Yeah, it's all
if
love.
You're offended, I'm sorry. Not much you can do about that. Cole dared me to say it.
I did. So general recommendations for how much you would want to intake or potentially supplement: in premenopausal women and men should consume at least 1,000 milligrams of calcium. Postmenopausal women, 1,200 milligrams. So that's total of diet plus supplement if you want to supplement. They don't recommend more than 2,000 milligrams of calcium per day because there are side effects associated. So yeah, I'm just going to say that, there has been a general recommendation of calcium and vitamin D supplementation in osteopenia, osteoporosis. We could get way more in the weeds on it, and I think we probably will at some point, but there's just controversy as to, is it worth it? Is it actually helping? Or is it making people feel like they're doing something before they start, like a bisphosphonate or something like that? Yeah, so there's controversy. I don't really have an opinion. I say if the patient wants to do it and that's going to make them feel better, and they have the money, whatever. But if they really ask your opinion, you might be able to tell them it's controversial, and if you have a balanced diet, you probably get enough in your diet. So primary sources of calcium in the diet: milk, of course, and other dairy products, hard cheeses, yogurt, green vegetables like kale or broccoli. I love me some steamed broccoli.
Yeah.
You just got to throw some salt on the top.
You have to.
Have to. Cereals, soy products, fruit juices usually are fortified with calcium, so have it in there. But yeah, Mike already mentioned the calcium supplements, but yeah, that's the recommendations.
So vitamin D. Vitamin D is obviously what's needed in order to absorb calcium in the first place. Typically, if we have like a deficiency from just not having enough vitamin D, whether the person doesn't go out in the sun enough, whatever the case may be, we would give either vitamin D3 or D2. D3 being more like the similar version that we get from the sun, D2 being more of a plant-based version. And there is a study, because there's some kind of debate on which one to use. There is a study, like a big meta-analysis that compares the two, and it does look like D3 is slightly more effective than D2. Now, whether that's clinically relevant in a patient, if you can't get D3, maybe not really something to worry about, but if you're interested in that kind of stuff and nitty gritty data, then you can. But the other thing to keep in mind is the patient's renal function, because in order to be activated, if I give someone vitamin D3 or D2, it has to undergo a hydroxylation reaction in the liver, and it has to undergo a hydroxylation reaction in the kidney to become fully activated. So if the person has chronic kidney disease, especially like stage 3, 3B or more, we definitely need to worry about whether or not they're even activating the vitamin D, and then go from there. So see the CKD episode for that.
Yes, we talked a lot about it because there is supplementation that you can give in people with kidney disease, and there's not really a reason to use the really high dose vitamin D for long periods of time, because they should either be replenished or there's something else going on. So just keep an eye on that if they are being on it for an extended period. The current recommendations for vitamin D in men over 70 and postmenopausal women are to consume at least 800 IUs or 20 micrograms of vitamin D per day. Lower vitamin D levels are not as effective, and high doses can be toxic. So we generally consider it a pretty benign drug, but it is one of the fat-soluble vitamins, right? A, D, E, and K.
Yep.
So you don't really just pee it out like you do a bunch of stuff. It can accumulate. Really high doses can increase risk for kidney stones, confusion, weight loss, frequent urination, other non-specific stuff like nausea, vomiting, constipation, all that sort of thing. Things we want to avoid with just an over-the-counter supplement. So if you don't think the patient needs it, bring it on down to one of the over-the-counter doses, or check and see if there's something else underlying going on.
So let's move into our bisphosphonates. Sound good?
Yeah.
So bisphosphonates, these are going to be, we'll start off with our oral agents first. So one of the ones, these are all going to be something you're probably familiar with, but alendronate, Fosamax, is one of the most common ones used. And there's two different versions. We can either dose it as 5 milligrams daily, which is usually what we would see in like prevention in patients like postmenopausal women. If it's actually treatment, we typically do either 10 milligrams daily or 70 milligrams once weekly, and we can kind of dose it either way. And that would be used for treatment versus the 5 milligrams or 35 milligrams once a week for prevention. And then also 5 milligrams daily if it's glucocorticoid-induced osteoporosis.
Yes. And what these two are doing is, or at least Fosamax first, inhibits osteoclast activity through the pathway. It's going to inhibit bone resorption. So talked a little bit about the patho. That's how that works. Resedronate, Actonel, is another one. It's also an anti-resorptive agent that does not affect bone mineralization. These have a very low oral bioavailability. That's why it's important to take them as prescribed. And usually on the label, there will be a pretty long label about not eating or taking with a full glass of water, sitting up for a while, and not eating or drinking for a certain amount of time. Part of that is the oral bioavailability, and part of that is other side effects. The bone uptake of what is metabolized is about 20 to 80%, so it also varies significantly, and the remainder is excreted in the kidneys.
Yeah, like Cole said, so you have to stay upright for at least 30 minutes and then 60 minutes if you're using the once monthly version of Andronate, the Boniva. And then some of the other warnings to kind of keep in mind would be issues with the esophagus, where the tablet can become stuck, which is another reason why you need to remain upright and drink with a full glass of water, as well as osteonecrosis of the jaw.
Yes.
It can potentially be a risk as well. And then hypocalcemia is another thing we have to consider. These do have renal dose adjustments, and so if it's less than 35, if your creatinine clearance is less than 35 mils per minute with alendronate, or less than 30 with the other two, then it's not recommended. But typically, more common adverse effects is going to be like our hypocalcemia, potentially hypophosphatemia, dyspepsia, nausea, vomiting, things like that.
Yeah.
Heartburn.
And with treatment for osteoporosis in general, but also with bisphosphonates, there's some concern with long-term therapy. So a lot of times they'll recommend a drug holiday for a while. I think it's after about 5 years or so, but they can increase risk for other fractures. We mentioned osteonecrosis of the jaw, which is a different thing, but increased risk for certain fractures over long periods of time, and they just essentially won't work as well after a period of time. So I think there's different labels and different links on each one, so you just would want to check that out if you're initiating somebody on that or reevaluating them after a series of years.
And then we also have injectable versions. So we have a Bandronate injectable as well, which is a 3 milligram IV every 3 months. And then we also have the Reclast, which is given 5 milligrams IV every 2 years and for prevention. And then it can be given 5 milligrams every year for actual treatment. And these, again, can cause hypocalcemia. The Reclast has renal dose adjustments, so creatinine clearance less than 35, we need to probably not use it. And then the same issues as far as like GI upset, issues like that, we still need to consider.
Isn't Reclast like a yearly infusion or something like that?
Yeah, that's what I just said.
You did? Okay, I was reading.
Cole, you weren't listening to my
called
points.
It's called reiterating for purposes of learning.
Amazing.
That's what that is.
Amazing.
That's what we are.
Simply stunning.
That's how we do it.
Yep. Well,
so the only other
professional.
metabolism modifier, that's kind of how these are classified, the ones we've been talking about, is the calcitonin salmon, which is fascinating. But it's a nasal spray, which I dispense fairly regularly to a few patients. Yeah. Is something else that can be used in treatment, specifically for postmenopausal women with osteoporosis who are more than 5 years post-menopause. Not necessarily a first-line agent. We usually consider the bisphosphonates our first-line agents, but there are other indications for some of these other drugs we're going to talk about, depending on where the patients are relative to menopause and relative to their fracture history and risk.
Yeah, and as far like calcitonin, I think of even being used in like an emergency situation where the patient's coming in with really high levels of calcium in the system. I believe that's more where I kind of am thinking about. I hope I'm saying that right, but that's where I would typically like a calcimimetic type effect instead of like giving Sensipar daily.
It's one of those things where the outcomes aren't great as far as reducing incidence of fractures, but it does increase bone mineral density. So not first line.
All right. So looking at our estrogen agonists, antagonists, like our Avista, which is going to be more like a SERM, a selective estrogen receptor modulator. And that is going to be used in prevention and treatment in postmenopausal women, as Cole stated earlier. The big issue with this is anything that is affecting estrogen levels, we are automatically thinking increased risk of VTE, potentially increased risk of death due to stroke, especially contraindicated if the patient has a current VTE or if they're currently pregnant. And then, as far as adverse effects, we're thinking mostly like hot flashes and peripheral edema, things like that, leg cramps.
Flu-like symptoms, yeah.
Yeah. And then we would also want to discontinue this about 72 hours prior to any like planned prolonged immobilization due to the risk of clotting.
Yeah, that's not what we want.
No, definitely not. And we also have our combination of conjugated estrogens and beta-doxaphene, which is the Duave. You don't see that one too often. At least I don't see that one too often.
I don't either.
But that's typically used as for like a prevention postmenopausal women that have an intact uterus. So it is because it's just straight estrogen and there's no progesterone component. We need to make sure that it's we're using that, or I'm sorry, because it's an estrogen combination with another agent, we can use that in patients that have a intact uterus that have not had had it removed. So the black box warning is pretty significant. Also increased risk of VTE, obviously, but also endometrial cancer has been noticed in this, and dementia as well as a potential. And then contraindications if a patient has a history of breast cancer, any kind of uterine bleeding, any active VTE or pregnancy, we can't use it.
So another class are the parathyroid analogs. So essentially a synthetic parathyroid hormone. Forteo is the first and the one that you'll probably see more often. Teriparatide is the generic name. It was approved for men and women at high risk of fracture due to primary or hypogonadal osteoporosis or postmenopausal osteoporosis in women. Those are two different indications. It's a parathyroid hormone. Parathyroid hormone is very important, like we talked about earlier, in regulating calcium and phosphate, and is going to play a role in that resorption and bone building phases. Another one that I've seen recently, it's one of the newer ones, and I've actually dispensed it a few times, is Tymlos, another synthetic peptide analog of parathyroid hormone. Similar indications, postmenopausal women who are at high risk for fracture because they've had a prior osteoporotic fracture, or they have multiple risk factors and have failed or are intolerant to other therapy. So usually these are reserved for not last line, but later in therapy, and they're both injections as well.
We have to use them for typically 2 years or less because there is a black box warning for an increased risk of osteosarcoma with these. Those were seen in rat studies, but definitely something that we need to at least make sure the patients are aware of. Also can cause some hypercalcemia and orthostatic hypotension, things like that we have to watch out for. Leg cramps, pain, nausea, orthostasis, those are kind of the more common things we would see. And then with Tymlos specifically, we would see a potential for an increase in uric acid, so it could precipitate out a gout flare as well. But yeah, these are more expensive agents, and like Cole said, kind of used more in specific patients.
Yeah, and they're almost always going to need to be approved by the insurance. And if a patient is uninsured, no way they're going to be using it unless they're on a program where the company pays for it.
Yeah. All right. What else we got?
So there's a couple last ones. Monoclonal antibodies, which we mentioned earlier. Prolia, denosumab is the older one. Evenity is the newer one. Prolia, I believe it's an every 6-month injection. But it targets the rank L, the nuclear factor kappa B ligand, which plays a role in that process of bone resorption. Generally dosed 60 milligrams, like I said, every 6 months. It's a sub-Q injection in the upper arm, upper thigh, or abdomen. Its indications are more specific men at high risk for fracture who are receiving androgen deprivation therapy, or non-metastatic prostate cancer. Also glucocorticoid-induced osteoporosis in men and women at high risk for fracture. That's Prolia. Evenity is a different monoclonal antibody. It binds sclerostin, which is one of the regulatory factors in bone metabolism.
Did you mention the osteonecrosis of the jaw with Prolia?
No.
So that is another issue with Prolia, just like it was with the other agents we talked about, but the osteonecrosis of the jaw is something that they have to consider. So there's an increased risk seen with invasive dental procedures. And so there was some talk for a while about whether or not you could use this if a person was undergoing some sort of oral surgery. But a lot of the oral surgeons will not operate if they have a patient that's been taking this. They let it get out of the system first before they'll operate.
Yeah, it's tough because it's lasts a while. Interesting.
But yeah, and then there's also been issues with atypical femur fractures, and then hypocalcemia, as we would imagine, is at risk as well. And then one of the things to consider is if you're going to discontinue the denosumab, that you could get a potential for rapid bone loss. So you would want to consider like an alternative agent to kind of take its place once you do switch them off of it.
Yeah.
But yeah,
that's the main stuff. There are other like calcimimetics, other estrogens, other things you would consider. I'd say those are the primary ones, and a couple of the new kids on the block.
Yeah.
Avenity and Timlos.
Bam.
There you go.
There
Everything you need to know
you go. Well,
to get started.
Before
learning
you learn
about osteoporosis.
the real stuff.
Yeah. We we'll take an episode where we take a disease state and it's like, let's just walk through this algorithm, and I guess that's what we do with patient cases, right?
Yeah, pretty much. That's what we do with every. What it's come down to is we don't know what we're talking about anymore because we've gone too deep, and we just have to walk through basic reviews for everything. So it is what it is.
Until we do patient cases, and then we walk through.
And then we just do diabetes over and over again.
That is very true.
So, it is what it is.
Maybe we'll throw osteoporosis in there on our next patient case.
Ooh, that would be...
It's not that bad.
Yeah, how hard could it be?
How hard could it be?
Yeah, we'll probably consult an expert before we do that to you guys.
We like bringing on experts.
Yeah, that's way better than us assuming we're correct.
Yeah.
But, cool. Anything else?
That's all I got on this one.
All right. Well, thank you guys so much for listening. Thank you all for the nice emails we've been getting lately, and we've really appreciated that. We've heard from a lot of you guys actually. Instagram, LinkedIn, we've been getting all kinds of messages, so it's been cool to kind of have you guys reach out to us, and we really appreciate the support and everyone listening. Like I've said multiple times, I'm stunned that any of you take the time out of your busy lives to listen to us chat on about nonsense. So we definitely appreciate it. And if you ever have any questions, concerns, please reach out to us on any of the social media platforms. Our emails are listed below. And if you do like the podcast, make sure you subscribe, leave us a rating, and then check out the other platforms. We have t-shirts and all kinds of cool stuff like that available now in case you want to get super trendy like all the cool kids. And other than that, keep on listening. We appreciate it. Thanks.